See, bladder stone is not common as kidney stone. Okay, it accounts for around 5% of all urinary tract stone, and a lot of basics of bladder stone is similar to the kidney stone or ureteric stone, like the composition, similar composition, oxalate, uric acid, all those calcium, non-calcium stones are same. X-ray characteristics, that is, some stones are radiopaque, some are radiolucent, the same, exactly same. The one difference is how they are formed, mode of formation, right? How they are formed, or the etiology is slightly different than kidney or ureteric stone. So basically, we classify the stone according to mode of formation as a primary bladder stone and secondary bladder stone. So bladder stone that are not related to any infection or obstruction and usually arise in the kidney and that fall down into the bladder and become enlarged, and these are actually regarded as a primary bladder stone. Primary bladder stone is more common in children than adult. Okay, it's more common in that age group. And usually, if you treat the primary bladder stone, they usually do not reoccur. Okay, as in compared to secondary bladder stone. Secondary bladder stone means this is bladder. Okay, this is the muscle of bladder. Let me draw the system of male. Okay. Okay. Fine. So if there is any cause of bladder outlet obstruction, for example, BPH in male, right? Stricture urethra in male or female. Okay. Any problem in the in the urethra, like stricture urethra or phimosis, like that. Any cause of bladder outlet obstruction in male or female, there will be stasis, right? Stasis means the urine will stay there for a longer time. And as you know, urine already has these stone forming agent like oxalate or calcium, urate, everything is there. But if the urine does not flow, then these crystals start to precipitate, and forms stone. So whenever there is a stasis, there is a chance of stone formation. So this is the one cause of secondary bladder stone. If there is any infection, okay, infection, UTI, infection can cause stone. I will explain that, right? Some bacteria can increase the pH more than 7.2, like Proteus, and that lead to steroid stone. Some bacteria can make it more acidic, less than 5.5, such that the uric acid stone and cystine stone are common. Same thing happens. Or if there's a foreign body means the most common foreign body in the bladder is catheter. If there is a catheter here, for a longer period of time, then the crystals that is found in the urine will attach to these foreign body and forms stone. So secondary stone are those stones that is formed inside the bladder due to other causes like bladder outlet obstruction or foreign body in the bladder or an infection. Okay. So so this is the way how we can classify the bladder stone according to mode of formation. See the surface of the stone. Oxalate stone are more spiky, cause more pain and hematuria, and uric acid stone are more smooth, chalky white in color, and smooth surface. Similarly, the multiple branching pattern stone in the bladder is known as jack stone. Chemically, it is oxalate stone. Okay, but the one thing is slightly different. If you remember, in kidney and ureter, the most common variety of stone was oxalate. But in the bladder, mostly we find uric acid stone. See, as you know, the bladder is very sensitive to any irritation. So suppose this is bladder interior. This is the opening of the ureter. This is the opening of the neck. So this area, see, the area between the two ureteric orifice and the bladder neck, this is the opening for the ureter, okay, ureter opening. So the area between two ureteric orifice and neck of the bladder, this triangular area is known as trigone, internal trigone, or as trigone. This trigone is very tightly adherent to the underlying muscle. Okay, so when the trigone is irritated, it lead to the irritative symptoms of LUTS, that is frequency, urgency, nocturia, dysuria. As usual, there will be pain. So pain is also a very common symptom. Okay, the most common symptom is irritative LUTS, that is frequency and urgency are more common than pain. Obviously, when the stone is inside the bladder, it will cause the pain also. So if you know the normal anatomy, the bladder lies at the suprapubic region here, right? So the stone, the pain related to stone, patient feel pain at suprapubic region. Okay, usually pain is dull in nature. Sometimes it is stabbing variety, but usually dull in nature. And the pain radiate to the perineum downward, or you can say labia majora or penile area. Okay, and the pain is aggravated by upright posture. Upright posture means if the patient stand, the patient feel more pain, because once you stand, the stone will irritate the trigone, and that can cause more pain. Okay, obviously, for any stone disease, if there's a jolting or movement or jumping movement, the stone also moves, causes pain. When we have to empty the bladder has to contract. So when the bladder contract at the end of micturition, the bladder mucosa collapse around the stone and causes severe pain. So pain increase more commonly at the end of micturition than the beginning of micturition. This is a term known as Stangueri. Stangueri means, see, this very small child, they cannot say they have a pain. Okay, so whenever they pass urine at the end of micturition, I've already told you, the stone, irritate the bladder neck and bladder mucosa more often. Then the baby cry loud and hold his penis or labia majora. So at the end of micturition, the child cries a lot and hold the external genitalia, and they withdraw their leg. So this is known as Stangueri. Okay, so please remember these things. Symptoms: as other stone disease, patient also have hematuria, because when the stone irritate the mucosa, injure the mucosa, there will be bleeding, and the hematuria is always painful. Okay, see, this is bladder neck. Okay, this exit point of bladder. So see, if there is a big bladder stone, then this big bladder stone cannot obstruct the opening, because it will be above the opening, but once the bladder is filled with urine, it will go away and the urine can easily pass. The small stone can tightly fit at the bladder neck and can obstruct. Or which stone can cause acute retention of urine? Answer is small. Small bladder stone can cause acute retention of urine. Okay, so not the larger stone. Okay, because it can cover the outlet but cannot obstruct the urinary flow. Okay, this is important. See, remember that bladder stone are of two types. One is primary, other is secondary. In adult old age, secondary cause is more common than primary. Try to identify, is there any secondary cause behind the bladder stone or not, especially in the male, elderly male, age more than 50-55 plus. If the patient come to you with the bladder stone, then please search for BPH. Okay, search for neurological damage like neurogenic bladder. There's so many other causes of bladder outer obstruction. Search for those causes. Okay. Um, see, this picture is showing you the small stone is obstructing the bladder neck. Sign means examination. As usual, just like kidney stone or ureteric stone, sign is not an important factor in diagnosis, because if you try to palpate, you will not be able to palpate a stone, right? So sign are usually unrevealing. It's not that much important, but yes, always examine for secondary cause. Like, don't miss DRE in the case of adult male. Okay, the DRE will give you idea about the enlarged prostate. If there's a history of neurological damage, for example, spinal cord injury, stroke, and other situation, then please do neurological examination of urology that I've taught you, right? Examine the neurological system, mainly focusing on bladder, right? Do that. Okay. What are the investigations we do for bladder stone? 55 years old male, frequency urgency nocturia, that is LUTS, plus hematuria, painful hematuria. Obviously, you're thinking of there could be something in the bladder, especially bladder stone is there, right? Associated with the pain. Then, obviously, we follow the same pattern. We do urine routine and culture. Okay, always do renal function test. Now, as usual, you can directly go for non-contrast CT scan KUB, or you can first do X-ray KUB and USG KUB. Sometimes this is enough. We don't need to do CT scan. This much is enough. Okay, so it's your choice. Or to have a detailed idea, you can do CT scan later on. Ideally, either you do this one or this one is okay, fine. Because bladder stone, you can get a like very good idea with ultrasonogram or X-ray. Okay. Okay. Even routine and culture, I've already told you. Watch for pus cells, watch for RBCs. Okay, and watch for the pH. pH are important, right? Some stone are formed in acidic pH, some are formed in alkaline pH. Always check kidney function test whenever there is urolithiasis. Do that. X-ray QB. In X-ray QB, mostly you'll diagnose a stone because most of them are radio opaque. So you can see the round, radio opaque shadow at the pelvis. Okay, and obviously you can do ultrasonogram of QB and prostate. As usual, the stone is seen as a echogenic structure, means white structure producing black shadow or acoustic shadow. You can see that. This is the echogenic structure, white structure producing posterior black shadow. Okay, and also this is the outline of bladder. This is urine. You know that, right? You can know the size as well. Size is important for management. That's why you should know that. And the good thing about ultrasonogram is it will give a gross idea of kidney and the ureter, means whether there is a hydronephrosis or not, whether there is any other additional stone in the kidney or not. You can see that. That's why it gives us a good idea about the whole KUB region. The ultrasonogram KUB and prostate will give you idea about the prostate size also. Uh, Whenever you do an ultrasonogram of our KUB and prostate region, it will not only give you idea about the bladder, but also it will give you idea about the prostate in male, which is one of the common cause of bladder outer obstruction. If you do non-contrast CT KUB, then easily you can see the stone. Okay, uh, hypertensive structure found inside the bladder. You can see that. So cystoscopy is basically done just before the surgical intervention. We introduce the cystoscope telescope inside the bladder, and just you can see the bladder stone. Direct visualization, but we don't do it just for a diagnosis. Okay. Okay. Now Let us see what are the treatment options that we have. Again, emergency management, surgical management, preventive management, and identify the cause and treat the cause. So we don't observe, there's no such observative management for this bladder stone. Emergency management means, see, what emergency could happen in bladder stone? The only emergency that may happen is if the stone obstruct the bladder neck, okay, it lead to acute retention of urine, acute retention of urine. So if there's a stone obstructing the bladder neck, the best thing that you can do is do catheter immediately, okay, urethral catheter, pass catheter immediately, apply a lot of jelly there, and then push it back. Push the stone back to the bladder, and then plan for definitive management later on. Okay, so this is what emergency management is. In the case of bladder stone, always try to identify whether there is a secondary cause or not, and if you found it, treat that cause as well. Okay. Prevention of recurrence. Regarding prevention of recurrence, I have already explained several times. We have some general guidelines and some specific guidelines. General guidelines give us idea about how much water to drink, what to drink or not to drink, which type of food we should take. Okay, what are the food restrictions that we have? So I've already explained in detail in our kidney stone chapter. So just follow that one. And after stone analysis and metabolic analysis, we give a specific guideline or specific preventive advice, right? See, I will explain this thing. Now let us focus on surgical management. As kidney stone and ureteric stone, the surgical management that we have is divided into minimal invasive technique and open or conventional technique. So minimal invasive technique is obviously now the treatment of choice. Okay, we have basically two options very commonly done is cystolitholapaxy. Cystolitholapaxy means cysto means bladder, lithalo means stone, paxy means crushing by mechanical force. Cystolitholapaxy. Cystolithotripsy means cysto means bladder, litho means stone, tripsy means to break down into pieces by using other forces like laser or pneumatic rod. Okay. ESWL, is an extracorporeal shockwave lithotripsy. We same principle we follow as in the kidney stone. The shockwave is produced outside the body and passed into the bladder and break into the fragments. And if the stone is very, very large, and if the stone is associated with other pathology like BPH, then we have to go for an open surgery, that is open cystolithotomy. Okay, cystolithotomy. Cysto means bladder, litho means stone, tomy means to cut. Cut the bladder to remove the stone. Cystolithotomy. Let's see the option one by one. Cystolitholapaxy. Cystolitholapaxy means, here what we do is we introduce our machine with telescope inside the urethra to the bladder, identify the stone, and crush it mechanically. I'll show you the video and then you'll understand. This is applicable for a smaller stone, up to 3 centimeter stone we can apply it. Okay. This is the machine, lithotrite. This machine, okay, this much is introduced inside the bladder. Okay, this is the handle that we can hold by our hand, and this is the telescope you can see, and it is connected to the TV by a camera. Fine. See, let me show you the magnified view of the anterior part. See this one. So once we see the stone, we fit the stone at this jaw here, okay, and then we pull this handle towards the other handle, and then this crossing unit also moves towards the stone. Once it moves towards the stone, it crushes the stone. Okay, so it is just like crushing the stone by our hand. Okay, so you can see the two stones, right? So once we go inside, wait, see, yes, see, So now, once we have identified the stone, now you can see the crushing arm is there. Now it will hold the stone, and see, we are crushing the stone by our hand. Okay, see, crushed into pieces. Once the stone comes in between the jaw and the sheath, we crush it between that. The one thing you have to be very careful while crushing it, the mucosa of the bladder may get injured. Okay, so there's a technique to crush. We hold it and we lift it upward and then crush it. Okay, see, the stone is coming out through the sheath easily. Obviously, we use normal. You can see there was some injury to the mucosa. See, you can see the mucosal piece is also coming out. So the ideal would be hold the stone, lift the stone upward, and then crush it. Then it will not injure the mucosa. Okay, we use normal saline while breaking it, because normal saline will allow you to visualize the stone. Okay, so once you remove everything, the surgery is done. And we collect the stone and send the stone for stone analysis. Now stone, the blood is clean with stone. There is no stone at all. This is Cystolitholapaxy. Now Cystolithotrypsy. Here what we do is we go inside and see by cystoscopy, and we use some energy source like pneumatic rod, laser, ultrasonic. So we break it. We break the stone into small fragments and bring it out to the cystoscope. Okay? It is usually done for larger stones up to 6 centimeter. We can do that. Okay, and we use this the pneumatic rod. I'll show you in video. And once we locate the stone, we can break it. Let us see the video first. See the profile. See the profile of patient. 56 years old male, presenting with the pain and hematuria. Okay, DRE has showing small BPH is there, and the stone was found to be around 3 to 3 centimeter. 3 to 3 centimeter. It's up to 6 centimeter. We can do cystolithotrypsy. Okay. So see, this is a cystoscopy. Okay, this is a cystoscope. You can see the urine is coming out. Okay, and this is a telescope. This went inside. You can see this is the urethra going up. This is the verumentanum. Yes, this is the prostate lobe. You can see this is the posterior urethra. Now we are inside the bladder. See the stone. Now tell me, obviously, this stone is it. See the difference between two stones, right? This stone is more spiky. See the surface, it is very spiky, right? This must be oxide stone. Previously, it was uric acid stone. See, just before breaking it, we are just observing the bladder to see any abnormal pathology in the bladder. Okay, so once we see it, then we will break it by using the energy source. Okay. This is prostate gland. You can see right and left lobe are there. It's not kissing, not obstructing the pathway. See pneumatic. Okay. See, this rod is a pneumatic rod. You can see the handle over there, and the long rod is going out. It is connected to the machine. That machine generates the air pressure. And what does it do is it will move the rod front and back, just like whenever you use a hammer to break stone, exactly same thing happens. The rod moves front and back, so that it will hammer the stone and break the stone. Okay, so this is pneumatic rod. Then you can pass this rod to the cystoscope and go inside. Okay, and then you will target the stone and break it out. When you break it, we see the monitor. Okay, in the monitor we can see the stone. So it's just showing you the movement that we have to adjust while breaking the stone from outside. Wait for a while, you will see the interior view as well. Now see the interior video. So this is the weight stone. This is the pneumatic rod. Now see, just like hammering. See, wait, see, it vibrates. So front and back. just like hammering the stone, and it will vibrate and hammer it, and it will break it. Okay, see. So you have to target the central part of the stone and break it into pieces. So just break it into multiple pieces, and it will come out through the cystoscope. That's why we avoid the open surgery nowadays, because see, this is surgery, you don't have to open the abdomen. Okay, just break it into small pieces and bring it out through the cystoscope. You can use laser energy as well, but fine. But it is not like in the case of ureteric stone, the stone will move into the ureter. Here, the stone cannot go to the ureter. That's why you can use pneumatic rod and easily break it. Okay, it is cost-effective technique. If you use laser, it is very expensive to the patient, and this is equally effective. So you can use pneumatic rod, no problem. The difficulty is as you hammer the stone will move, right? So the bladder should be partially filled. Okay, you should focus the stone at the center and break it out. And always control the hand, because if you just go more deeper, then it can injure the mucosa and even puncture. So control your hand. Okay, don't allow the rod to move very deeper, so that it will injure the mucosa. So you need to practice for that. This is an ilex evacuator. You can apply that ilex evacuator at the cystoscope sheath and just pump it out. You can suck the stone out. Okay, you can do that. See, pump the evacuator. If you pump it, the water will come out with ilex evacuator. See the stone fragments, and now you have to send the stone fragments to the stone analysis. If there is a larger stone, or you don't have these machines, everything, then you can just open the abdomen by financial incision, that is transverse incision at the suprapubic region, just as the cesarean section. You just go inside, open the bladder, and remove the stone. Especially in the case of larger stone, and if the stone is associated with other pathology like BPH, you can do open surgery, no doubt. Okay, see the stone, how large, like a bigger stone which cannot be broken by the lithotripsy or lithotripsy. In that case, you can just go for open surgery and remove the bladder stone. Okay, ESWL may be used, but when you break the stone by ESWL, then you may need to remove the stone by doing cystoscopy, because the fragments may not come out easily. So yes, after ESWL, you can take it out with the help of ilex evacuator. You can do that as well. Okay, please answer this question. Yeah, secondary bladder stone refers to bladder stone due to infection, bladder stone due to foreign body, or bladder stone due to any bladder outer obstruction. So here option is infection, right? Uric acid stone. Usually uric acid stone is, it may be pure uric acid, or it may be uric acid with calcium. So Zack stone is a multiple branching auxiliary stone. Okay, it is found in bladder. Answer is D. 58 years old male. Okay, presented to you with the complaint of frequency urgency and painful hematuria. Okay, these two are the key point, and the age. See the age. Okay, and he already has a prostate enlarged. He has BPH, so he is having BPH for last 4 years and taking medicine for BPH. Okay, so a patient who is a diagnosed case of BPH have developed a new symptom, that is frequency urgency more often main, and also 2 episode or 1 episode of painful hematuria. And all the examination was normal, and the DRE shows there is a enlarged prostate. Wait, so what could be your diagnosis? Obviously, there is a BPH, no doubt, but the symptoms of BPH is associated with the new onset of painful hematuria and frequency urgency. So it could be two region. One is either a patient of a BPH, okay, have stone in bladder or stone in lower ureter near the VUs over here. So these two could be the possibility: a stone inside the bladder or a stone in the lower ureter with BPH, right? So this could be our differential diagnosis because of these symptoms. Okay. So once I have these diagnoses in my mind, then I'll go for an investigation, right? The investigation will be, I'll do urine routine, okay, urine culture, renal function test, and ultrasonogram and X-ray QB. Okay. So here you have seen the past cell is plenty. RBC is plenty, right? Now there's no growth. That means it is just an hematuria. No infection is there. Kidney function was normal, and X-ray QB was showing a round radiopaque shadow at the pelvis. So I know this is the case of bladder stone, no doubt, and he already has a BPH, right? So now I will do ultrasonogram QB and prostate region. The ultrasonogram QB is showing us the echogenic structure, the white structure inside the bladder producing black shadow, right? This is stone, no doubt, and you can measure the size of stone as well. Okay, size of stone as well. And as you know, this was the case of BPH. When the lateral view was taken, the BPH was also found. Enlarged prostate was found. Okay, so now we have confirmed our diagnosis is confirmed. The diagnosis is BPH with bladder stone. Now the question arises, what will you do? Patient has two pathology. One is the stone, which is due to BPH, right? So you have to address both pathology. You can address both pathology at the same setting. Mostly we do in same setting, or sometimes we just do one procedure now and one other procedure next time. Mostly we do in same setting. Regarding BPH, I'll discuss later on. Okay, so for bladder stone, we have the options depending on the size. If the size is smaller, like less than 3 centimeters, you can go for Cystolitholapaxy, and a bit larger, you can go for Cystolithotrypsy. Very large, you can go for open technique. Okay, and for BPH, you can go for TURP. What is TURP? I'll tell you later on. It's an endoscopic procedure by which we can cut the pieces of prostate slowly. Okay, or you can go for an open technique. Suppose we are trying for endoscopic technique. Suppose this is bladder, this is prostate. Okay, now you may say, sir, if the prostate is enlarged here and the patient has stone, bladder stone, now tell me, which surgery will do first, prostate or stone? See, basically, if the instrument can go easily inside, okay, first break the stone and take it out, and secondly, you do BPH surgery. Because if you start with the BPH, then the problem is there will be a lot of bleeding, and a lot of bleeding will obscure the view of the stone and difficulty in doing stone surgery later on. So if you can go into the bladder by taking the instrument inside, then best first break the stone, clean the stone, and go for BPH surgery by TURP. Okay. If not, then what we say is just cut a small quantity of the prostate, just little amount, and then go inside and break the stone and finish the prostate surgery later on. So the ideal would be do the stone surgery first, followed by BPH surgery. Ideal. Sometimes you cannot go inside. In that case, you have to cut the prostate slightly and then make a pathway, go inside, break the stone, then do the prostate surgery later on. If the stone is too very big, and if you are planning to do open surgery, then that time also you can do open bladder surgery for stone and open prostate surgery at the same setting. You can do that. Okay, these are the homework for you guys regarding the bladder stone. Okay, and these are the references I've used to make the slide. If you have any question, you can ask me right now.